Olikoye Ransom put in. And his legacy is still resounding. I mean, he brought to the fore the idea of primary health care as a cornerstone of our healthcare system. And all that we're talking about primary care and developing primary care systems, a lot of it came from the work he did. We also know what he did with immunization, health policy reforms, public health awareness, international collaborations. And like I said earlier, his legacy is still resounding. So one of the great leaders we've had in healthcare in Nigeria. The key challenges we have, I mean, we all know the problem, and maybe, we shouldn't really spend too much time on this. Infrastructural challenges, access to healthcare, access to finance. Patients can't afford healthcare. 70% of healthcare payments are made out of pocket. We have a shortage of healthcare professionals. People are leaving the country in droves. Quality issues, health information system, and then we all know how the underbelly of Nigeria was laid bare with COVID and what happened with all the challenges we had there. Now, I mean, yes, those are the challenges, but I think those are the things that we're grappling with. But we have to also look at the light at the end of the tunnel, and there are many opportunities that we can look at. I mean, one of the things that I believe is that we need to redefine our healthcare system. There's overwhelming evidence today that a lot of lifestyle choices are the cause of a lot of diseases moving forward, like metabolic syndrome and the various offshoots, diabetes, hypertension, even cancer. And just preventative care, focusing on lower cost approaches to manage this healthcare issues we have. And there are great opportunities here. There are great opportunities with telemedicine, digital health, or technology adoption, so to speak. Financing reforms to make healthcare more accessible, partnership and collaborations. I think 60 to 70% of healthcare needs in Nigeria are provided by the private sector. And I'm a trustee in the Healthcare Federation, and the vision of the Healthcare Federation is how to activate the private sector to support the government in the national strategy and create some kind of what I call beyond PPP, beyond public-private partnerships to public-private integration. These are major opportunities. Empowerment of healthcare professionals. I think the empowerment will start from just care professionals. Community-based health promotion, and then pharmaceutical industry development. We import most of our equipment, consumables, and pharmaceuticals. So opportunities to actually improve on this. And one of the things that I think I heard about last week is the approval of incentives for the importation of APIs for pharmaceutical products. So there's a lot happening in terms of opportunities in healthcare in Nigeria. So if we look at the structure of healthcare leadership, this is according to the National Health Act of 2014. As a federal structure led by the Federal Ministry of Health with various parastatals, and that is headed by our Minister of Health. Then there's the National Council of Health, where all 36 state commissioners and the Director General of the Primary Healthcare Development Agency are supposed to meet regularly to implement the vision for healthcare development in Nigeria. And then there's a National Primary Healthcare Development Agency as a separate parastatal because of the importance that we have defined for primary healthcare in Nigeria. And similarly, we have the State Ministry of Health, the State Health Council chaired by the governor, and commissioner and representatives of the relevant government agencies, professional bodies, and civil society organizations. And similarly, there's a primary healthcare management board at the local government level. So overall, the leadership structure for healthcare in Nigeria, as defined by the National Health Act, is designed to create a coordinated and integrated healthcare system that emphasizes collaboration among the various levels of government, as well as active engagement of communities and stakeholders in the planning and delivery of healthcare services. The Act seeks to promote equity, accessibility, and quality in healthcare delivery across the country with a focus on primary healthcare as a foundation of our healthcare system. Now, ladies and gentlemen, I'm not in government. So my approach to this lecture is to look at what should be rather than what is. But this is what our Health Act defines as the state of play. Now we can question the level of implementation and how effective the system is. I can't answer that, but I think I'm here just to put some ideas into how things might be for more effective implementation. And further to that, we also have a very, very clear vision for healthcare in Nigeria. The vision for healthcare in Nigeria is to ensure the provision of accessible, affordable, and high-quality healthcare services to all its citizens, with a strong emphasis on achieving universal health coverage and improving health outcomes across the country. The overarching goal is to create a healthcare system that is effective, efficient, and responsive to the needs of a diverse population. So specifically, the vision for healthcare in Nigeria encompasses the following aspects: universal healthcare, equity and accessibility, quality and safety, community participation and engagement, health promotion and disease, strengthening of our health systems, research and innovation, collaborative governance and leadership. So that's really what we as a country, where we are trying to go. So in summary, the vision for healthcare in Nigeria aligns with global efforts to achieve sustainable development goals related to health, with a focus on ensuring access to quality healthcare services for all citizens. It encompasses a commitment to universal health coverage, equity, quality, community engagement, and the strengthening of health systems to improve health outcomes, as well as well-being for the Nigerian population. We will all agree that a lot has happened in healthcare development in the last few years, especially in the private sector. And how do we drive things forward? So this is where I want to discuss leadership of our healthcare system. So what I did was to say, listen, what do we need in terms of our capabilities to be able to effectively implement a national or state strategy for health? And these are the characteristics that I came up with: visionary leadership, strategic thinking and planning, collaboration and diplomacy, effective communication, political acumen, decision-making under uncertainty, cross-sectional understanding, crisis management and resilience, inclusivity and equity, result-oriented accountability, global engagement and representation, adaptability to change, ethical and value-driven leadership. Now, these are all competencies that can be tested for as we move forward. And I also feel that one needs to look at I'm looking at things at the national level and at the state level. These are the characteristics of leadership. Then I thought, well, let's look at our large hospitals. We have our chief medical directors as the CEO of these large hospitals, the teaching hospitals, for example. What skills and capabilities are required to be effective in driving the leadership of these hospitals from a sustainability and a development point of view? And I came up with these characteristics: leadership and strategic planning, financial management, healthcare administration expertise, data analysis, decision-making, change management and innovation, patient-centered care and quality improvement, stakeholder management and collaboration, communication and interpersonal skills, regulatory compliance and risk management, ethical decision-making and integrity, crisis management, emergency response, and cultural competence and inclusivity. So basically, these are competencies that we doctors are not trained to have. And so how do we bridge the gap between the person running the hospital and being able to acquire these skills, be able to effectively deliver a very clear vision for a large teaching hospital? So these are questions we can discuss. So really, I believe for effective leadership, we need to really look at the strategic plan for either at a state level, at a hospital level, or at a national level. And we have a national strategy. And I think every state as a strategy for healthcare. But I believe that perhaps we need to focus more on competency-based employment, because after all, the job of leadership it's a role that one has to play. So how do we ensure that the person who's holding this role has the right capabilities? How do we ensure that the job that is at hand is getting done? How do we get them to report? How do we manage performance? And how do we do a competency gap analysis to say what are the gaps that are in place, and how do we fill these gaps? I believe these are the things that as a nation, to see effective transformation of healthcare, we need to look at moving forward. So, ladies and gentlemen, in closing, I think strong and visionary leadership is essential to catalyze the transformation of the Nigerian healthcare system. It is crucial to continuously explore new approaches to hospital management, advocating for a multidisciplinary model that leverages the expertise of medical professionals and healthcare administrators, ensuring optimal healthcare delivery and efficient operations. I think my experience is that the whole system is too doctor-focused, and doctors are very good and very key people in terms of their role, but we need administrators, we need people who have financial management to ensure that when we were in last week, the discussion was that healthcare is seen as a social service, but it costs money to run a hospital. And the government is spending billions of naira in running these healthcare hospitals. How do we make sure that they are financially sustainable and there's growth and development? I think we need more skills in the leadership to achieve that. I am confident that through the collective efforts of dedicated and forward-thinking leaders, we can chart a course towards a healthcare landscape in Nigeria that prioritizes accessibility, equity, and superior health outcomes for all Nigerians. Ladies and gentlemen, thank you very much for your attention, and I look forward to the collective endeavor to realize this transformative vision for healthcare in Nigeria. Thank you very much for listening to me. I'll be happy to take some questions. Thank you.
Thank you so much, Dr. Ajayi. Dr. Ajayi may not be able to be with us to the very end. He asked, so we'll take about 2-3 questions. If we have questions, please put it in the Q&A, and we will find a way for him to quickly answer. If we have a question, please put it in the Q&A so as to manage the time better. Can put the questions in the Q&A as soon as possible. Thank you so much. A lot of people are clapping. I can see electronically. We are really grateful, Dr. Ajayi. Beautiful. Somebody has asked, will you be able to share your slides with us in a PDF form so that we can circulate to attendees, sir?
I will send that to you, sir.
Oh, beautiful. Thank you so much. Another doctor, one of the CMD, has thanked you for this lecture, and impactful and very precise. We are grateful. Okay. There is, wow, I want to quickly, where can I find that? Fantastic. Blessing, quickly ask your question. Blessing, you raised up your hand. Can you ask your question? Mrs. Ibitoye, you raised your hand. Can you quickly ask your question? Okay. Maybe she raised her hand in error. All right. There are no questions so far. If we have any question, send it to me. I will get answers to you for you automatically. And okay. One of the doctors would like to ask question, Dr. Olufemi Omololu, one of my mentors. He's been a mentor to me for years now. So Dr. Omololu, can you please speak? You can unmute.
Thank you very much, sir. Thank you, Dr. Ajayi, for that very insightful lecture.
Dr. Omololu yes, is the medical director for the Lagos Island Maternity, by the way. Thank you.
Please confirm you can hear me.
We can hear you.
Yes, can hear you, Dr. Mololu. Nice to have you here.
Thank you, sir. So thank you for the lecture. And yeah, as mentioned, I'm into the leadership position, and it was quite a transition coming from being a clinical person into, someone in administration. And one of the challenges, at least we have in the Lagos state system, which we've been trying to bridge the gap over the last few years, is trying to prepare doctors for these leadership qualities. I mean, looking at those 12 leadership positions, looking at those 12 qualities you said you must have, and when one tries to rate oneself, one sees as a continuous work in progress. But trying to be proactive, I mean, what can we really do to now start to make doctors move into that line of thinking for leadership, and not that is when they get there, they now start to learn all these things, because it's almost like it's when you get there, you start to learn on the job, So, I mean, what structures can be in place? I know in some places, not even doctors do these leadership roles. So what can we do as a country to start to make sure that people are well equipped for this? Because like you rightly said, doctors are not trained. So what strategy, what structure can be put in place that could be long-standing? Thank you.
No, thank you very much. I think there's a concept in management called succession planning. And basically, thank you for the question, Dr. Mololu. Succession planning is about preparing people for the positions that they're going to take. The question that I'm going to really put in the air is if you look at what happens, we take our best doctors and we make them into managers. That creates a shortage of doctors at the leadership level of healthcare in the first place. Now, how do we get them ready for this position? And it's all about training. And I think doctors that want to aspire for these kind of leadership positions, I believe, need to take some time out and go and acquire the skills that are required to be able to effectively deliver. Because learning on the job is not the way, because you're already there. And by the time you understand, what you need to do, I will give myself as an example. When I started Bridge Clinic, I remember going to meet a businessman who's late now, and I told him that I wanted investments. And what he said to me, I'll never forget it. He said, you're about to change your job. I said, what do you mean? I'm a doctor. He said, no, you're about to change your job and become a businessman. So I will only invest if you enroll in the Lagos Business School Chief Executive Program, because you're not going to start working as a doctor. You're collecting investments that you have to return on, but you're sitting in the consulting room seeing patients. How do you manage the finance system? How do you manage the marketing? How do you have a clear strategy and he made me go to the business school, and going to business school opened my eyes that is actually a different set of capabilities that you need to effectively lead a system, even if it's a hospital. And so I think it's about training. Thank you very much for your question, Dr. Mololu.
Thank you, sir. There are two other questions we'd like you to take before you leave. The question came from one Adeyonyi Adeniji, and he's saying, is there a dichotomy between practice management and administration?
Well, I think it depends on scope and scale. In a small practice, a doctor can run his practice, see his patients, and have someone look after his books. It's not too complicated. But as we start to evolve into large hospitals, where there are multiple departments that need to be integrated, there's a concept called a visa, which is the V is visioning. So there must be somebody who is doing the visioning. There's somebody, the I is integration, where you're integrating the vision into the different departments. Then there's the systematizing of the business, which is where you're doing your processes and your procedures. And then there's A, which is action. So doing the work, which is A, is one thing, but someone needs to do the S, someone needs to do the I, someone needs to do the V. So in a large hospital, there's a very big difference. And I think a doctor that wants to aspire to run a large hospital needs to have the training to effectively deliver that role. Thank you very much.
Grateful. There's a question on the need for, can there be a succession plan And how do we go about managing the issue of interference of politics in the appointment of CEOs in hospitals? That's the last question.
Well, thank you very much for that question. I think those are part of the problems we have to deal with in our system. Because politics is politics. It's very difficult for me to prescribe against that, but it is a challenge because if you go in and you decide that this is the person you want, and the political fathers don't agree with you, they will put who they like there, and that's the system. I think we have to accept it, and that's one of the challenges we have to deal with in evolving our health system forward. I don't have an answer to it. So I'm sorry, but I understand the problem.
Thank you so much for finding time today, and we are really grateful. Thanks for the recommendation. There's one more question I just saw now in another platform, and that's from Dr. Mojisola Odeku. How might we crowdsource resources to enable us to execute these transformative ideas? We have policies and roadmap, but they are not executed innovatively. Although you have spoken about this already, so maybe that might. So she's talking about how can we gather resources or crowdsource resources to enable us to execute this very beautiful transformative ideas of yours.
Well, thank you very much. Well, I think like everything starts from leadership because, like we said, the problem is a leader away from a solution. So we can come up with, if you have the right leadership and they understand the challenges. For example, I saw recently in Lagos State, I saw it on social media that the Lagos State Commissioner has created a committee to look for good leaders to come onto the boards of government hospitals. Excellent initiative. Because you can't as one person have all the solution, but by creating such a committee, and I think he's also vested them with the right to set up the boards, inaugurate the boards, and set up controlling systems for the board. So that is crowdsourcing as a way of solving that problem. So I think it's all about leadership, their leadership awareness, leadership understanding of their role, leadership understanding of the importance of collaboration. And if you have the right person at the helm, then a lot can happen. Thank you very much.
Finally, sir, thank you so much, sir. The question is here I would like to answer, and that is, how do we prepare doctors for this leadership role before they assume those positions? The Business School Netherlands has put a program together that will be helpful to development of leaders in the healthcare sector. And this will be shared again. This information on this will be shared when all the speakers have already spoken. So just stand by and we'll be able to share what you need to do, who you need to reach out to be able to get this done. Thank you so much, Dr. Richardson Ajayi, for a very beautiful presentation. We do not want you to go. We know that your spirit will be with us. So
I'll be here for a while just to listen to the other speakers.
All right.
Thank you very much, and thank you for letting me come first. I appreciate you all.
Thank you.
Bye.
All right. Okay. Now, at this point, we would like to bring in the second speaker, and that's Dr. Mrs. Kemi Ogunyemi, the Special Advisor on Health to the Lagos State Government, and who has served in the transformation of the healthcare delivery system for decades now in Lagos State. I've known her as a very key transformational leader, and it's a great privilege to have her here to speak to us about what we need to do to enrich collaborative leadership in the healthcare space. Welcome.
Hello. Thank you so much for having me, Dr. Lere. I've been thinking about this topic for a while. So first things first, just to show you how women can multitask, I had to change my computer, and my PowerPoint is on that computer, and I've been listening to Dr. Ajayi, whom I know very well. Thank you so much for that lecture, I would say. But as I was listening to you, I had to transfer manually. I'm typing, I'm listening to you, and I'm typing so that I can have at least 6 flat slides. So sorry, there are no beautiful pictures, no colors. I'm actually quite good at PowerPoint presentations, but I've got my laptop here that has it, but I'm actually using another one. So sorry, that's just network for you and all sorts of things.
If you could send it to me from your laptop, then I
Okay.
can help you.
Okay, I should have done that. But
I can also help you in changing you to the last speaker if you want. That gives you like 5 minutes to 10 minutes to be able to do that, if you want that.
Let me just do it, and then when it's ready, you can actually send it out to your participants if they don't mind. But I mean, I'm going to show the slides. It's just plain. It's just black and white, and sometimes it's nice to have those visual things and you listen. But I'm sure they just want to listen to the substance, not listen to my thing. So let me just share it. It's just the normal heading, so then it will give me my talking points. Yeah, is that okay? I'll still share it.
Please go ahead, man. Yeah.
Okay, all right then. Oh, can you see it now? Okay. Yeah, okay. So thank you so much for having me. Thank you, all the people that have tuned in. Dr. Ajayi, that was really good. And obviously, since the three of us are talking about the same topic, we're going to be saying a lot of things together. But I'm going to come from a different perspective in terms of I agree with all the things you've said. But I'm also going to say the things that I'm not too happy about, and then I'm going to use myself as a person who is in leadership, my kind of like how I got to where I am right now as the special advisor to the governor on health. So I'm just going to go through the leadership stuff so that we all just have an idea of. I'm sure I'm speaking to a lot of people who already are in leadership and know what Dr. Ajayi and I are basically going to talk about, and my other speaker as well. So for me, collaborative leadership is effective teamwork where people from diverse backgrounds with different ideas come together and they make decisions. Good decisions for whatever it is they're working for. It doesn't matter. It doesn't have to be healthcare. It could be anything. It could be in the corporate world, banking and all that. But it's very, very important because leadership is now become a topic in healthcare. And we're now following like a business model because now healthcare is a business because obviously you need the money, you need the people, the right people to actually provide the services that you want to provide. So who's a leader, like who's a collaborative leader? So a collaborative leader basically wants the organization to succeed. It's the leader that allows the organization to succeed depending on what it is, how they're leading. So they believe that engaging people, carrying people along, and seeking other opinions are necessary for the organization to succeed. And then also the staff trust the organization where there is collaboration. So in other words, you're working in an organization, like I said, don't let us look at health. You're working in an organization and they're asking you for your input into how they're running the organization and in all the services that they're giving. So the staff feel there's a sort of buy-in and the staff feel, oh, we're part of this organization. That is why some people stay in organizations for over 30 years. I used to work at Emory University, and there were nurses there who had been there for 20 years, and it just baffled me because it was like they were part of the organization because they were included in every single thing, all the changes that were going on in the organization, they were aware of, even if they were not the ones making the final decisions. So when we look at transformation, collaboration, some people have asked me, what's the difference? Everybody says transformational is the best kind of leadership. There is no best leadership. Everybody is different. Some people have their situational leaders, their adaptive leaders, and all sorts of leaders. Some people say the old ones where we go into autocratic and democratic, which is kind of like out of the we don't really talk about those anymore because there are all sorts of leaderships, and people have done a lot of research to find how do you lead? what's the best way to lead depending on where you are. So transformational leaders have to have collaborative skills. And that's, I think all leaders have to have that. When collaboration is practiced, it fosters buy-in, like I said earlier, cooperation, successful change management, which is something that is obviously going to happen in our system now, motivates the staff, encourages innovation and creativity. Like Dr. Ajayi said, no one person knows it all. And that's the key. I want people to get at the back of their minds that even though you're a leader, you're not the only person that has all the ideas. You're not, and not only that, you're not the one going to carry out your ideas anyway. Some people, implementation is for other people to do and do correctly. So let's go into healthcare, since we're all in the healthcare space. The health system, healthcare is a complex system. Definitely in Nigeria, it is complex. It's complex because it has many parts. There's no one central person. It's different people coming together to ensure that this system works. So the system has different things that make it work. One is dependent on the other, is dependent on the other one. And so all these parts come together to make a whole. So it's a complex system where professionals, as well as non-professionals, with different experiences, work towards a common goal. And at the end of the day, we're all listening to this. What is it about? It's about that one patient. All the patients that come to us. That's the reason why we have a healthcare system. Health is important and it's for the people. So everything we do, all the changes, all the transformation, all the people we hire, it's all so that we have that one common goal, is to ensure that the patient has positive outcomes. Whatever the outcome is, as long as the patient is satisfied with how that process of getting to where they are at the end, that's what it's all about. And so, like I said earlier, in healthcare, you have different parts, such as clinical care, you've got finance, you've got support staff, you've got coordinators, you've got quality improvement staff, and risk managers. So we have issues, obviously, in our system. And that's why, hopefully, with the new leadership of Professor Pate and Dr. Alausa and the rest of the states, all the commissioners, all the SAs will come together and bring changes that we need. And from even my conversation with them, everything has to start. We have to basically start from the bottom, clean it all up. So going into cover, my next slide is actually, I'm kind of like jumping slides because I'm going to teach each topic one by one, and then I'll be able to expand it. And I'm going to use, I said earlier that I'm going to use myself as an example. I'm a nurse. In Nigeria, we practice a medical model. It's that simple. If you look at every single leadership that concerns health, it's all a doctor. It's like, to be a doctor, you're an automatic leader. So the head of this first place, the head of this place, the head of this place, all the agencies, they're all doctors. This is it. When you go to medical school, you become a doctor, bam, leadership is yours. But for me, leadership is not like that. Leaders have to want to be leaders. Leaders manage people. Leaders manage all sorts of things. They have to have all sorts of qualities, skills. And so a leader is the one managing the ICT department, a leader is managing nursing, pharmacy, and all that. But it's not just your profession, your clinical profession as a doctor, as a nurse, or as a pharmacist that makes you the ideal person to be a leader. Some people do not want to be leaders. They do not want to manage people. They don't. And so they're thrust into it. Because you're a doctor, you're next in line. So your experience, the number of years you've spent, and I'm talking public now. In private, they go out, they're deliberate. I'm looking for a leader, and then they interview you, and they ask you all sorts of leadership questions. Oh, excuse that type of healthcare leadership. The D is missing. So private sector can do that. In public sector, and generally, people, oh, you've been there the longest. It has to be a doctor to be this. Even some of our laws are what's it called? When we have a process, when they say, who is the person we're looking for? They always must have a medical degree. So like Dr. Molulu said, because I was in health service commission, and when I came back from the US, this was about 9-10 years ago. It was one of the first things I noticed because I was interested in leadership. So I saw it and I was like, oh my gosh, is that how we peak? First of all, apex nurses, that means the nurse is the leader of the nurses in that hospital. And is that how we peak the doctors? It's level 17, has been there before everybody else. Is this, and then bam. And Dr. Omololu is right, you just thrust in there. So unless you actually have the skill and the ability to be an effective leader, you'll be okay if you have all those skills. But if you don't, you struggle, like you said. And some people even had to send themselves to school to learn about leadership. And so Dr. Ajayi is right in terms of how do you get somebody ready for leadership and all that. So that's one of the issues we have. In one of the challenges is that it's a medical model. However, you're wondering how I got to where I am. Thank God for people like my wonderful, amiable governor, who saw it fit. He didn't just pick me because, I'll just pick her. But he made that bold decision. He looked at my CV. And how did my CV get that attractive? Because I decided when I was in, actually studied in America, and I just thought, I'd like to be a manager, a clinical manager. I'd like to go into leadership. How do I get there? I started going for courses, no matter how small, recruitment and selection, managing conflict, all those little, because all the levels are different. And gradually, I worked myself up. I did my master's in healthcare administration, as well as my master's in nursing, because I did like the clinical aspect. I went for my oncology program, so that because I like cancer nursing. And then I decided, you know what, time to actually go for my doctorate in healthcare administration, because I was intentional. It's because I was interested in that aspect of healthcare. I could see all sorts of things that were missing. I've had the advantage of being exposed to civilized, when I say civilized, healthcare systems that have actually grown in the US and in the UK. And I noticed that all the leaders had certain educational qualities. And not only that, they were actually in positions of leadership. So at Emory, I was always kind of like the first, if they wanted somebody to join a committee, whatever, my hands raised up, because that was what I wanted to do. And so I came to Nigeria, did some other things. I was head nurse at the Cardiac Renal Center. I started my doctorate 4 years ago. I'm done now. And then I got into Health Service Commission, where I had an opportunity to show some leadership skills and adapt and actually be on the table to make decisions. And then the rest went from there until I got the call that, you're going to be a special advisor. Now, the reason why a lot of people celebrated that was because it has always been a doctor. I think they had one pharmacist years ago. For all those leadership positions, commissioner, SA, and not all states have SAs, SSAs, all of them, they've always been doctors. And there's nothing wrong with that, because some doctors are fantastic. I can tell you, not just because Dr. Omololu is here, he's actually a very, very effective leader. Everybody struggles. I struggled and all that. It's like, okay, how do I handle this? Because there's no smooth leadership. You will always have the people that will test you. And it's just how you come out of it that matters. So he's a very effective leader. We've worked together several times, very innovative, very creative and all that. So he's one of the good ones. But there's some leaders, they become leaders because they're doctors and they just don't have the skills. And it's not that they're bad. It's because we have not helped them develop. We have not done a good job. And when I say we, the people who appoint these leaders, we have not. You want good leaders, you train them to be leaders, you give them opportunities and all that. And that is where, in the public sector, that is where a lot of people, that's where we've kind of like failed, and we're changing that. And I'm an example of how it's like, okay, we don't have to have doctors all the time. There are doctors that probably do the same job. And I'm going to tell you this, that even though as a nurse, I have a doctorate in healthcare administration. And as far as I'm concerned, I'm doing a darn good job too. And I have a lot of people who are supporting me because I can't do it myself. And I'm learning. So I'm a fast learner as well. I'm learning. There are some doctors who have said, no, it is not right. This position belongs to a doctor. And so with that kind of mindset, how are you going to have collaboration? Meanwhile, on the other hand, pharmacists and non-doctors and nurses, they're saying, yes, yes, yes. It puts pressure on me because I have to do a fantastic job in the time I'm here in this position, so that, because we follow a medical model, somebody doesn't come around and say, there you go, you didn't have a medical doctor in that position, and that's why things failed. And so let's revert back to putting a doctor. So we need to move away from that medical model. Like Dr. Ajayi said, we need to look at what people have, the skills. We need to promote people in developing people, not promote, developing people to take over from whoever is leaving, so that you have a fantastic succession plan with no problems when that person takes over. So you're not going backwards, you're actually going to, so you're in one position, the person goes, the next person comes and continues the good things that that person had been doing without any break in the system. So if we do this, because like some people say, okay, everybody's complaining that the health sector is broken, is this, we're losing people. Who are the leaders? Who have been the leaders? So collaboration is not just about, oh, let's all sit down, and what a collaboration is saying, we want to make a decision, we want to change something. Let's call this person to represent this person. Let's call this person, let's call this person. And that was what we did with the Board Advisory Council. So Commissioner and I sat down, he had some ideas, I had some ideas. We have doctors, we have 2 nurses, we have a pharmacist, we have a lawyer from outside, private, and we have an administrator. They're the ones that are going to sit down, learn about the law, the law that are in Lagos State about boards, learn a lot, and then sit down and put their brilliant minds together. And that is, we're collaborating with them. They're sitting together. It's not just one profession that is dictating how this should be. That's just basically what we've seen, and we're changing, at least as far as I'm concerned, in Lagos, where I work. So, and that goes beyond that. Even in the hospitals where, and I will use Dr. Molulu because he was the one that spoke, and I know Adam Maternity very well. It's like the health management board. I think all the hospitals have this. They have all the heads of every single department sitting together and giving the MD, the medical director, Dr. Molu, information for him to make an informed decision. He cannot make it alone. He cannot have 5 doctors helping him make a decision that would affect pharmacy, nursing, even the cleaners. So you've got the head or facility manager or the engineer. You have all these parts that make a whole that will make the system really, really work. So we have issues, obviously, in our health system, huge issues. And the first one is the Jaffa syndrome. We can talk till we're blue in the face about this. People are still going to want to leave because we are not there yet where we are doing anything to stop them or discourage them from leaving. Most of us are doing our part, but it's very difficult for someone to say, no, don't go to that hospital in the UK, or don't go to Canada, stay in Nigeria, let's suffer together and all that. It's going to be better. You're not. However, we can actually do the brain gain. And what I mean by that is that, yes, people are leaving, but there's some people that have been there for a while that actually do want to come home. They really want to come back to Nigeria. The kids, the empty nesters, they've done what they want to do. They've bought their houses. I mean, they have what it takes, and now they want to give up. And there are quite a few of them. And a few days ago, the governor spoke to an interventional cardiologist by Zoom. We were there. And he said, what will it take for you to come back? Because obviously you're coming and going quite a lot, which a lot of them do. They come, they go back because they've got a life in another country and they've got bills to pay as well, but they still want to do what they can do for Nigeria. And he asked that what, and he said, well, you know, most of us are coming back to private practice because private practice is where our needs are being met. And those needs are infrastructure. Our infrastructure has to change. We've got to do better. They need the tools. They've got all the knowledge, the skills, but then you come to Nigeria and you do not have the tools to use your skills or your abilities. And so he mentioned that. He mentioned, and that's why a lot of people are coming, those who are coming back to private practice. Now, so we have all these fantastic doctors, physicians, nurses, pharmacists coming back to Nigeria, but going to the private sector. How many of our people, our citizens, can actually go to the private sector and actually get that kind of care? So we're looking at it, we're sitting down together with different people saying, what can we do in the public sector to be able to say, for other doctors to come in and say, actually, I do not mind working in the private sector, in the public sector. That will help. I don't mind teaching medical students. I don't mind giving my time, rather than even just the medical outreaches are fantastic. They are fantastic, and a lot of people are coming down, and you know, people, those who can afford healthcare to pay anything, they're actually accessing care through the medical outreaches. So, but we need to do more so that people can come into the private sector. I know what's her name, the CNN, I'm sure all of you saw that on social media about the CNN Issei Sese, the CNN reporter who was in, I believe, Senegal and then Sierra Leone or Senegal, and brought her mother to Lagoon Hospital. And she said they saved her mother's life, who was in ICU and all that. One of the first things that came to my mind was, fantastic. I mean, great, because this is Nigeria, but that was a private hospital. So they have a fantastic ICU. The patient was there for 5 days, survived the whole thing. Could we have provided the same thing in the public hospital? And those are the kind of things we're looking at where, yes, we're partnering with private sector. By the way, 60% of our patients go to the private sector. So, and government cannot do it alone. I know some people don't like to hear that. Government cannot do it alone. So we are partnering with private sector, huge partnership, so that we're giving equal care, you know, and equal access to healthcare. You can choose wherever you want to go. I've talked about moving away from a medical model. Basically, that just means we sit down and all the talents we have, all the talents where we're able to identify those talents, we're able to pull people, sit on the table, let's discuss. That will help, because in Nigeria, we all know it, there's that rivalry or whatever. So doctors want something, they'll ask for something, the pharmacists will ask for the same thing, the nurses will wait to see whether the pharmacists get it, and then the nurses also will ask, and then there's that discord and all that. But when people, like I said earlier, in collaborative transformational leadership, when people feel like they are part of a system, they will give the best, their performance will go up. This has been researched. It's all evidence based, that people will feel invested and they will give the best that they can, because that's the whole point. You want the best out of everybody. That also means inclusive leadership. So I'm part of leadership at a state level. I'm able to sit there. I'm able to talk to the commissioner and say, okay, and bring a different perspective, because both of us are there in control of the health system in Nigeria, but we're not doing it alone. We're doing administrative work, and we're using our skills and our experiences to lead people, to lead the people who do it. Is it HEFAMA who gives out the licenses? They're the ones who go out there and monitor and give the licenses. They come to us, we discuss. It's all administration, and we lead them. So I'm there too. And I'm talking to Lasambos, the ambulance service. I'm having meetings with the leadership, who most of them are doctors and all that. And we're sitting there together together. And there are wonderful people in the Ministry of Health in Lagos. Don't think anybody's looking at me like, okay, what does she know? She's a nurse, I'm a doctor. I don't feel that, I don't see that. And we're working together to make things better because our goal is the patient, is to improve the system. So we're working with private people, we're working with patients. I believe when I was at Emory, it was the same thing. Anything you do that is to improve something for the patient has to be involved in it. We must have a system where patients who have actually used the system, who have gone through the process of being admitted and discharged, can tell us their experiences. We need more of patient satisfaction surveys. We need them because we need the data. So private hospitals will ask the questions, how did we do, whatever, your food sucks. So they go back and go into the diet and say, what is it about the food? Your outpatients, the waiting time, which everybody, that's a global problem, by the way. Waiting time is so bad. I waited 1 hour to see the doctor. Everybody's looking at what's the system? What can we do? Because the patient said it. They are the ones who feel it. So we need to ensure that we carry the patients along. We also carry family members along because they're the ones that look after their patients. And then all the other people, all the other elements come together, we sit down and we come up with the best plan for the patient. I know Dr. Ajayi talked, and he said it's so eloquent, so right. When he was saying it, I said, oh, well, I don't need to say anything more about this. That succession plan is so important. So the next person should be ready to take over from the one that is retiring. So those are the kind of things that I believe will give us the leaders, the leadership, an effective leadership when we're transforming the system. We cannot do the same thing over and over and over again. We cannot have, for example, there's a committee where everybody on that committee is they're all professors. Fine, maybe we do not have people to fill in whatever. So they're all going to think alike. They are all going to think alike. There's nobody else that can come in there and say, oh, have you thought about this? Have you thought about that? And be a different perspective so that you can, because the point is you're transforming something. Transforming means what it was before, you want to change it. But you can't change it if you keep on using the same model, the same way that you're going to. So including others into that style of leadership is very, very important. Sending people for leadership courses. I will give one final example. In my dissertation for my doctorate was actually, the topic was actually leadership and the managing attrition rates and retention, especially during COVID. Because during COVID, people were sick, people were unfortunately dying, and we were extremely short-staffed, and that's what's basically gone on. And I myself was amazed at, there were nurses, in fairness, there were nurses, and even the nurse leaders did not even understand where the junior nurses were coming from in terms of there was no sync. The nurses told me how they felt about leadership, what was lacking during COVID era. The leaders painted some fantastic story about how they looked after the nurses, but the nurses didn't feel looked after. So there's a gap there. But one thing that did come out as well was that they mentioned what Dr. Ajayi was saying, that we do not go for courses. And even when we apply, they tell us there's no money. So we're not investing in the people that are on ground, that have not japa. We're not investing in them. We're not investing in their development, in their growth within the profession, but we're promoting them. We are promoting them because when they get to a certain level, they're promoted automatically. They could be bad, but they will still be promoted because that's what we're doing. So there's so many things we need to look at, but when we all come together, we'll be able to change that from primary healthcare, all the things that are happening in primary healthcare, getting the chairman, the local obas and chiefs engaged in how we can get the grassroots in the community to access primary healthcare before going to the secondary healthcare, so that because there are obviously 3 layers. Don't just go straight to a general hospital. The primary healthcare centers are there. And that's one of the goals we're trying to reach here. We're trying to push LASHMA in terms of health insurance. And we need all the people in the community, the heads in the community, to help us achieve that, where people do have insurance so that they can have access to quality healthcare. It can be affordable as well, and they can actually have a good experience and not have to go to the secondary hospitals, which the secondary hospitals, we can build them more now. So one other thing that we are doing in Lagos State, in conjunction with the federal government, is, I'm sure some of you have heard about it, that we are going to have a new university in Lagos. And basically, part of that is to increase the number of doctors that are trained, medical students, increase nursing, increase pharmacists, and all the other allied professionals. So it's one big university of health sciences, health education sciences, and that will give us more, so that we can train more doctors. So we're losing them a lot, I know, but we're going to be training over 1,000 per year, and same thing with nurses, pharmacists, whatever. That's in the pipeline. It's in conjunction with, it's been something that Lagos State has been saying for a while, because LASUTOM is just not cutting it. We're not actually training enough doctors, nurses, pharmacists, and all that. So that's one thing we're looking at, and it's a collaborative effort. I'm part of the team. There are other people that are part of the team, and that is what we have. And of course, Lagos is a center of excellence, so we always start things first. So you have a nurse as an essay. I'm getting used to the doctor thing, which I cannot use in the hospital because we don't want to confuse the patients. But the point is that here I am, I'm qualified because I have an education in the things that I want to do. So I want to employ those who are listening, who feel, you know what, leadership is for me. If it's not for you, it's not for you. You do not have to be a leader. You do not have to be a manager. However, if you do want to go into that, just continue learning. Continue learning. There are lots of free online things where you can learn this and learn that about leadership. It's so important. You cannot be a leader without skills, without knowledge, without knowing, oh yeah, this, risk this. It's all part of growing, developing, and all that. So, and I know together, every single one of us doing our part. And if we're in leadership, learning more, doing our part, listening more, engaging people. I told an MD once that, you know, your hospital is so clean, but you're not the one cleaning it. It's that cleaner that's cleaning it. That means whoever is leading that cleaner has a system in place where you need to clean it at this time, you need to, so they have a system in place, which the leader, the MD may not know, but he's put somebody in place to ensure that they're doing it. And that's where all the, so that we don't micromanage people, and all the things within leadership, emotional intelligence, and all those things that come into leadership are so important, so that people can work together, come together, and we can reform the system of Nigeria and make the health system a much, much better one that is accessible to everybody, accessible to quality care, and also affordable. Thank you so much for having me. I hope that has helped and given a different kind of tilt, and so that you saw the same old thing we're talking about. Thank you so much, Dr. Lere. Over to you.
This is fantastic.
Okay.
You could see electronic clapping all over.
Thank
we are
you.
really grateful. I wish we have devoted almost a whole day to this thing. And then bring people together physically, but this is the starting point. We are really grateful.
Thank you.
I will make a summary of what we have presented later after the next presentation. We're going to call on the next presenter to present. Before she presents, we have a small, what do you call it? Dr. Pans.
Yes.
You have the film, or you want me to, you want me to share the film from here, or you are sharing it from your end?
You mean I don't have slides? I'm going to speak.
Okay. So when the film to be shown?
Oh yeah, go ahead and show the film.
Okay. Is it at the start now or when? That's
Yeah, go ahead and show it at the start. I think it's good for them, and then I will. That's
particularly
left.
after
Yes.
the doctor and the nurse have spoken, who are
Yes.
leaders. And so um, this is interesting because I saw it, when you spoke to me, I quickly looked for it and I'm just, wow, what's wrong with me? Okay, maybe I'm getting a little
It's
bit old. Okay, no problem. I will see it now.
Yeah.
I'm searching for it and I will see it. So good. YouTube. Cyst as this rupture. Good.
Are you a professional looking to immigrate legally to the United States? Today, we're going to talk about
So please, let's wait and just watch this film. Wow, what's happening? Files. Where's my desktop? Wow, 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 wow. Share screen. Basic. I think this is it. Yeah. Fantastic. Can we see it? Larry, is it showing?
Yes, sir.
Okay, thank you.
Disruption. When I say that word, what does it make you think about? Disruption defined as a disturbance or problems that interrupt an event, activity, or process. By its definition, it says the word problem. But today, disruption has a completely different meaning. When we think of disruption, most people these days, we don't think of problems, we think of solutions. And when we think of disruption, we think of technology and how it's completely changing our lives and industries around the world. When's the last time you stood up?
Obi, we've lost the audio.
Yeah. We've lost the audio.
Hello, LB.
You,
Yes,
but from
please.
a people point
We
of view.
lost the audio.
Let me tell you
Audio
why.
is
Start with
sounding here.
patience. Many of you have seen Norman Rockwell paintings
Larry,
of
can
the
you
doctor
hear the
making
audio?
close calls. He's got
Yes,
his
it's breaking. It broke for a while, but it's back now.
It's a
Or it's
network.
breaking.
It's a
Okay,
network.
sir.
Over the last few decades, we've gone from this really personal type of healthcare to one that's impersonal.
We've lost it again, LB.
LB, I think the audio goes off whenever you mute yourself.
And then you'll go to the pharmacy and wait some more. That
Yes,
whole
it's back
process,
now.
3 hours of your day, when you feel terrible. From a patient perspective, that's suboptimal. Now, what's happening in healthcare with transformation with technology is we are bringing healthcare back to the home. Think about the next time you're sick. You can get out of bed or just roll over. You turn on your computer, you log on to Doctor in Demand or Zipnosis, you answer a few questions, and guess what? The doctor shows up on your screen. The doctor has come to you. Technology has made the 360-degree transformation of personal to impersonal back to personal again. The patient has to be at the center. When we think about what's happening in the future with transformation, with technology, the patient is going to drive this. Because for the first time in history, patients are partners. The doctor knows best way of thinking is gone. Patients are saying, this is my life, it's my health, it's my business. Give me the tools I need to get engaged in my care. And they're going to start transforming things like we've never seen before. I have a patient named Sarah. She came to me because she had uncontrolled diabetes and her kidneys were starting to fail. I asked her, why are your sugars so bad? And she said, I have all these medicines and I don't know which is which. I don't know what to do with them. Some of them make me feel bad, but I don't know which one, so I just don't take them. When I met her, she was getting hospitalized 4 times a year. She was a mess, quite frankly. I asked her, have you talked to anyone about that? She said, my doctor's got 15 minutes with me, and 10 minutes of that time is sucked up with administrative stuff, so there's not enough time to talk to my doctor about the stuff that I want to get across. The current team of healthcare, the doctor, the patient, and the nurse who helps us, is not adequate. It doesn't give patients the options they need to get the care they need to get better. So think about the dream team. And this is what's happening now, and it's going to go all across medicine. In my world of kidneys, this is what we use because kidney disease patients are complex. We have the patient in the middle. We have the primary doctor and the specialist. We have our nurses and PAs. But what we've added to this is the health coach, either from the insurer or the companies that you work for. Your family caregiver. Either you're taking care of someone or someone's taking care of you. Technology is weaving this all together. And the person that most people don't recognize as a member of this team is the pharmacist.
Participate at the Africa Technology Expo coming to Lagos, Nigeria this June.
The pharmacist is the forgotten member of the healthcare team. And that's really too bad, because if you think about Sarah and her example, her issue was medicines. Who knows more about medicines than a pharmacist? I call pharmacists the doctor on the bench. And why? Because they're doctors. Most people have no idea that pharmacists are doctors, but for the last 20 years, everyone that's graduated from pharmacy school graduates with a doctorate in pharmacy. And with that comes knowledge, experience, and expertise that I don't have and never will have. The doctor on the bench has to get in the game. And how are we going to do that? Because they are the ones who can help our patients because we can't do it ourselves. If you think about Sarah, what we did for her is we set her up with a pharmacist to do something called medication therapy management, where she spent an hour with a pharmacist who went over every single medicine, how they interact with each other, what she might feel like, and told her and educated her about this. I can't do that. But most importantly, she got better. This problem, Sarah's problem, not taking her medicines, is called medication non-adherence. It's considered the biggest fixable problem in healthcare today. It's a $300 billion with a B, billion-dollar problem in this country. That's 10% of our total healthcare spend. So when you think about who does this affect, it affects all of us. We talk right now about the cost of healthcare. It affects insurers, it affects employers, it affects you, because it's your pocketbook, your copay that's being affected by this. And it's more importantly, affects your health. This problem exists for one reason. Over the last 25 years, healthcare has changed. People are so into the power of the pill that every time you go somewhere to the doctor or whatever, everyone wants a pill. Give us more medicine. And the drug companies are happy to do that because they're making a ton of money. And in many of the cases, pills are the right answer. But it's an interesting statistic, but in 1989, there were 300 million people in this country. Now there's 350 million. In 1989, there were 700 million prescriptions written. Last year, over 4 billion. That's 6 times as many. And why? Because chronic disease plays a role. Think of Sarah. She's not taking 1 or 2 tablets. She's taking 5 or 6 or 7 multiple times a day because she needs to take these meds to get better. When I think about how we're going to transform healthcare and what we're going to do it as a team. And it's this new team that isn't just me. When I think of myself and my colleagues as doctors, we've been trained that we are the answer to everyone's medical problem. We're the solution. As much as we want to be, we can't be. Because in today's healthcare world, we have too many limitations. Our capacity isn't there. What I'm trying to do and what I want to do, and I think the future of medicine is going to do, is bring that doctor off the bench into the game. And instead of playing a support role, they're going to be playing a starring role on that patient's team to help them get better. There are 300,000 pharmacists in this country who are waiting to get into the game, and we need to let them. So when I think back to Sarah, the last time I saw her, when she came to me, her A1C, which is a marker of diabetic control, was terrible, 12%. When I saw her last time, 7%, which is normal. Her kidney function had stabilized. She looked awesome. And the coolest thing, she hadn't been in the hospital for 18 months. It wasn't Dr. Shah who saved her and got her better. It was Dr. Smith, her pharmacist. So with technology and the future of technology being driven by patients and pharmacists joining our team in a way like never before, these are the new healthcare disruptors. Thank you.
Thank you. Thank you, Professor.
Yes, ma'am.
Yeah, thank you for sharing that.
Thank you.
Yeah, I can go on and make my own comments. Right?
Yes, please.
Okay.
Yes, please.
Again, well, good morning from Atlanta, Georgia. I have to really commend the 2 speakers before me. I think you all have done an outstanding job. You've covered a lot of, what I would like to cover, but I really wanted that video to be shared to kind of open the stage. And I hope those of you listening got a lot from it. What I would like to do is talk about my section in this presentation, but talk about it from the perspective of contemporary leadership. But before I go into that, I would like to stress that what I want to focus on is the fact that all pharmacists need to be leaders and to share the perspectives of leveraging leadership to improve patient care. I want to focus on patient-centered care. And I will also talk about some disruptive, which is what you all saw in the video, innovations, pharmacy-wise, that is going to clearly show us how important this is. So I will talk about, like I mentioned, contemporary leadership perspectives. I probably mentioned a few things, maybe some strategic leadership initiatives, imperatives in the current environment, and then utilize some examples of some disruptive, innovative pharmacy initiatives that have happened in US and those that is actually happening in Nigeria that I have been fortunate to be involved in. And it's good to hear that one of our speakers also, a previous speaker also is in Atlanta, so we're actually neighbors. So maybe we'll get a chance at some point to chat about Atlanta. Now, talking about leadership contemporary leadership perspectives, one of the things is authenticity. Also, importance of individuality, and also able to utilize constructive dissatisfaction to bring change either in an environment or in practice. In my case, what I did was to bring some change in the pharmacy practice. And then, of course, disruptive innovation, which we have heard, and I will share some of the things in the pharmacy practice that are examples of that. So starting with the authenticity, what does it really mean? It means you possess self-knowledge, you have knowledge of one's own strength and weakness. In other words, you're transparent to yourself. You view yourself as work in progress, which all of us are. That's why you're never satisfied with where you are. You know, an effective leader or a strong leader is always looking for opportunities. You're never satisfied with status quo. You're looking at, okay, how do I improve what's going on? What can I, as an individual, be able to contribute to that? You also create a sense of belonging. And the biggest thing you do is that you inspire your followers. You lead by some example. Some people may even say a servant leader. You demonstrate transparency, which we all know, open communication. You're transparent to say why you're doing so, and you listen to others. So communication, listening, involving others in what you do. So these are just a few examples I just want to share. Now, how about the importance of individuality? There are different ways you recognize that all the pieces are uniform and they move in the same way. They are interchangeable. They move in the same parallel pace. Each type of piece moves in different ways, like I just mentioned. So, but the one thing I want to bring us to is that, what do great leaders do? And you all have heard a lot of great comments from our previous speakers, but again, I'm moving this into the practice, the pharmacy practice sector. Great leaders, it's not just in pharmacy, but in general, they discover, they develop, and they celebrate. They turn one's particular talent into performance. They identify and deploy differences among people. They also challenge each person to excel in his or her own way. That's where that mentorship comes in. And they find ways for individuals to grow. In my case, and I'll just quickly spend like 5 minutes. Obviously, by now, everybody knows I'm a pharmacist. And in that video, you all heard the physician say, pharmacists are doctors. Well, I think I just want to clearly just say, we are professionals. We have the Doctor of Pharmacy degree, and it's happening everywhere. It's happening in the United States. It's now happening in Nigeria. And I was blessed to be part of that drive of what made it happen in Nigeria. We had what they call disruptors in the pharmacy profession. I would like to say during the time of the registrar of PCN during his time, he was somebody that felt like, oh, we really need to make a change, innovative. And then he had a lot of great stakeholders that worked with him. And I was fortunate to be asked to be part of that team, being a member of NAPSA, Nigeria Association of Pharmacists and Pharmaceutical Scientists, and also being that I've been in US in various leadership positions. I was, pharmacy residency program director. But anyway, I was part of that change and we made it happen. So I have a doctor of pharmacy degree. Now, I did not stop there. I felt like just having the degree wasn't enough, that I needed to have more experience. And that's why I did my residency. So I did a postdoctoral pharmacy practice residency program, a general. Then while I was doing my residency, I realized that I have a special interest in a particular field of pharmacy, which happens to be critical care nutrition support. So that's how I ended up doing an additional year. I'm specialized in critical care and nutrition support. So I became a specialist in nutrition support. While I was doing my residency, and I'm just sharing this to say that what we see happening in Nigeria now is happening pretty much the same everywhere, but we gradually evolved to where we are, and we're still evolving. While I was doing my residency program director, the nutrition support service they had in my institution was a service that actually monitored patients. And when I said monitored patients, that means all patients were on parenteral nutrition support every day. The team were around, they would look at the labs, they would do it, and they would call the physician and they would just give recommendations. I felt like we needed to do more to support the physician. We needed to do more to be part of that team that is providing that patient-centered care, meaning patient is the center of care and every one of them. So what did I end up doing? I ended up working with our physicians, with the key departments in my institution, and we changed our service from a monitoring to a management service, whereby automatically any patient that gets admitted to the hospitals, once they're screened for their nutritional status and they are malnourished, nutritional regimen is started. And then if it's parenteral nutrition, we work as a team and provide that. So to me, that was an example of a disruptive, innovative approach. Now, so why am I saying all this? What I'm saying is that all pharmacists, we have to have that leadership skills. We have to realize that we are leaders, and we can use our leadership, skills to help change what's going on with practice. Now, what are some of the disruptive innovation in pharmacy today? The unit dose. And for the pharmacists in the audience will understand this. We changed from bulk bottle of Flostock to unit dose to improve medication safety. Now, that is something that we pharmacists who are in the diaspora can continue to work with our stakeholders in Nigeria to see how are we doing this all throughout? Is it being done? And it's not that you just want to do it to make, you're doing it for the sake of the patient, for patient safety. Clinical pharmacy. Transition from dispensing role to unit pharmacist knowledge, to using the pharmacist knowledge to improve medication therapy. In my opinion, all pharmacists, whether you are in the acute care setting, or you're in the community setting, or you are even in the pharmaceutical pharmacy setting, you are clinical pharmacists. You need that clinical knowledge to do what you do effectively. For example, in the pharmaceutical care settings, pharmacists who are practicing in that setting, some of them are called medication science liaisons. These are the people, they do not detail about the drug, they detail knowledge. They are the ones that work with clinicians. Clinicians could be physicians, pharmacists, to come up with research. They are the ones that educate the clinicians in terms of the clinical knowledge about the drug. So now what is happening now, even in the community setting? In the past, community pharmacists really didn't realize that they were clinical pharmacists, but there were a lot of clinical interventions they were doing in the community setting. The community pharmacists are the ones that make sure that the patients stay well in the community. How do they do that? They do that by making sure they're doing medication counseling. They do that by making sure when they come to fill their medications, if it's a diabetic patient, they're looking at their A1C, just like that a physician said in that video. They are almost like, if you really want to know what's going on, they are almost like the caretaker. Now, the big shift now is for value-based pharmacy practice to happen in the community. What does that mean? That means pharmacists, community setting, in the hospital, we are now able to ensure that those kind of clinical pharmacy functions that we performing for the patients has some value. Insurance companies are now listening to this. Insurance companies are utilizing this information, and they're working with different pharmacy organizations to make sure, and that's something, again, that I'm hoping we can bring to Nigeria. Now, why am I saying this? What I'm saying is that we people in the diaspora, now the previous speaker, she was in the diaspora, she trained in the United States, same here, I trained in the US, but for the past 4 or 5 years, I've been coming to Nigeria 4 or 5 times. I have a pharmacy practice residency program that we're piloting in one of the institutions in Nigeria. Why? Because after being involved with the PharmD, it became clear that the next step is that pharmacy residency program. Why is that important? That's important because if we have to do this patient-centered care, and if we have to recognize that all disciplines are important, that we have to look at a multidisciplinary team approach in providing that patient-centered care. And one way to make sure that happens is to ensure that our pharmacists have the knowledge, they have the skills. And one way to get the skills and the knowledge is residency. What residency is saying pretty much is focusing on the practice component, exposing our pharmacists, whereby they're on the wards, they're rounding with the physicians, they're rounding with the nurses, they're visible to the patients, so they will have the opportunity to be able to practice what they are, So that is very, very, so I decided that I'm going to be one of the disruptors and work with WAPCP to see how we can at least pilot it in one institution using international pharmacy standards. And then once we have the data, then we can see how we can move it to the next level. So that's that clinical pharmacy, pharmaceutical care, integrated pharmaceutical care. It's happening everywhere. It should happen in the hospital. It should happen in the community setting. I mentioned about what the community pharmacists do. In the hospital, I'm also fortunate to be the founder and president of WASPEN. And why did I think that was needed? In all my years of coming to Nigeria, for doing medical missions, doing pharmaceutical care presentations, doing different things in Nigeria, I saw that definitely there was a high incidence of malnutrition in Nigeria, not only Nigeria, but in West Africa. Being that that's my field of specialty, I decided that I needed to form the NGO. So I formed the NGO named WASPEN. I could have named it NASPEN, Nigeria Association of Parental and Enteral Nutrition, but I felt like Nigeria is the first stop, but this eventually we need to get into West Africa. So this organization is going to its 4th year now. I do conferences once a year. In fact, somebody mentioned that Lagos is the center of excellence. And guess what? This June, Luth is going to be hosting my conference. And we're trying to send a clear message. The message is that patients who are admitted to the hospital, we need to screen them for their nutritional status. And if they are malnourished and their gastrointestinal tract is working, then we need to make sure we use the enteral route if they cannot feed enough. And if the GI tract is not working, then we need to do the parenteral. So we're doing these conferences every year. I'm preaching the message. So again, that's an example of a disruptive clinical pharmacy innovative approach. And the goal is that institutions in Nigeria will have what we call multidisciplinary nutrition support teams led by physicians, pharmacists, led by physicians, and the other team members will be your pharmacists, your dietitians, your nurse. But it has to be a team approach. So that's starting. So that's one, patient-centered medication management. I think we heard that in that video. We saw the power of that, the value. We saw, and my hope and prayer is that our physicians in Nigeria will continue to recognize how important it is to work as a team. But I will also say that we also need to recognize the scope of practice. Pharmacists need to recognize their scope of practice, that we are the ones that support the physician when it comes to, medication therapy management. Nurses have their scope. We cannot do what we do without nurses. Dietitians, that we recognize the scope of practice. So my message or my thought would be, at some point, we need to look at what is the scope of practice in Nigeria? Where is the information? Who ensures that happens? And if it doesn't happen, what are the implications? So that's something, if we continue to move in the direction we want to move, advancing healthcare and all that, I think that's one of the issues we also need to kind of look at now. Now, I mentioned some of the disruptive innovation examples. If you look at in US, when you're looking at pharmacy, satellite pharmacies, I think that's happening all over in Nigeria, very good move. Anticoagulation clinics, that's something that we need to look at what's going on in Nigeria. Vaccination in the community. If you look at what's going on globally, pharmacists are actively involved in terms of vaccination. I was blessed to be again part of that quote unquote disruptive team that worked with Professor Larry Ballard and some other individuals supported by PSN, DCN, to say we need to educate our pharmacists when it comes to vaccination. It makes it up. So we're making inroad there, we're getting there, but we also need to look at, are all our pharmacists able to perform these functions? Collaborative practice, it goes back again to that multidisciplinary team approach. Physicians, pharmacists, nurses working together. If there's one message I would like to give today, that is going to be, we need to continue to move in that direction. Physicians working together with pharmacists, with nurses, but everybody recognizing their scope of practice. And we also need to continue to remember the focus, the goal is patient-centered care. I think with our new administration, the Ministry of Health and all that, I think these are the issues. We also need to remember we have people abroad in the diaspora who want to support, who want to help. Somebody like me, I come on my own. Like I just mentioned, the residency program with WAPCP. And a lot of times when you do things, you're doing it for your people. You're doing it for your country. The reward will come somewhere along the way. So that's independent prescribing. And one thing that we also are working on is the value-based pharmacy practice, which is, like I mentioned earlier, really finally recognizing the value of pharmacists when it comes to clinical pharmacy to support the patient, and then having objective outcome measures that really shows the value of the pharmacist. For example, like the physician in the video said, the diabetic patient. That intervention that the pharmacist did, how can you say it has some value? It has some value when you can show that the A1C decreased to the normal, to the level it needs to be, whatever goal you set. Or if the patient is hypertensive, that you're maintaining the patient's blood pressure. But I think the biggest value, and that's something that I would love to see if we could, and maybe I'm not educated enough in terms of what's happening in Nigeria, is we have to start seeing the impact we make on the healthcare cost. The biggest value that pharmacist probably has is the fact that she has kept that patient well. That patient is is at home. That patient has not had any complications that is getting that patient sick to be admitted to the hospital. Obviously, if the patient is admitted to the hospital, the cost is going to be higher. So the pharmacist has played a key role in making sure that that patient stays well. So that is one of the values. So if we try, and then we're now beginning to also say, it's time that not only do we show the clinical value, as I just mentioned in terms of the A1C, and also the pharmacoeconomic, which is preventing admission to the hospital. If the patient is in the hospital, the pharmacists in the hospital, their interventions, working with the physicians, working with the nurses, also makes the patients well quicker, decreases the length of stay. Then we're also saying that for those pharmacists in the community setting, that let this value be translated to some financial incentive. In other words, they need to start being able to bill for their services. So those are some of the things, that one should kind of look at. So I think to conclude, I would say we have I think the physician in the video clearly mentioned or stated the direction that we need to look at in terms of changes. I would like to say that pharmacists are leaders, and we need to start developing our leadership skills to see how we can continue to use it to make positive changes in pharmacy that will have an impact on what we're doing in terms of the healthcare in Nigeria. I would also like to say that multidisciplinary team approach is clear, and it's all documented in the literature. I can pull studies, the value of team approach, not only on patient safety, not on cost, also patient-centered care, that the patients, they are focused. And I think one of the speakers also mentioned in terms of patient satisfaction scores, that's correct. And that if you have certain leadership skills, like the listening, the communication, and the transparency, we'll be able to utilize those skills to see where we're going to move the healthcare forward, And we need to look at how can we identify and work with some key individuals in the diaspora. There are a lot of us out here that really want to give back. And we recognize what's happening in Nigeria, but some of us keep coming. And I think together as a team, we can make changes in our country. So thank you. Thank you again. I think that's all I have to say. And I'll be glad to send slides to Professor Larry Bali for those of you. So I appreciate the opportunity.
Thank you so much. I mean, your presentation has actually you have put a icing on the cake. After watching the film, your further elucidation of the intention, of the communication in the film on the value of pharmacies is overwhelming. Thanks so much. We are really grateful. I want people who have specific questions, please. Chatting is on chat room. The questions should go to Q&A. So that I will just want to give a summary in 5 minutes and then go to Q&A. And then during this period, I will encourage both Dr. Ogunyemina as well as Dr. Pounds to please have a look at the chat room and take note of few questions that have been shared by participants. I want to answer a question which I found on the chat or Q&A. And that's the fact that Business School Netherlands is making effort to start a program on great leadership, transforming the Nigerian healthcare industry. We want people to be able to enroll for the BSN Healthcare Leadership Transformation Program, for which we have notable faculty members. Some of them are overseas, some are in Nigeria, and they'll be able to look at various dimensions, some of the issues that Dr. Ajayi shared in terms of those 12 subtopics are essentially covered inside it. And it will help you to build capacity to lead in pathway care intervention or wellness programs, irrespective of whether you are a nurse, you are an administrator, you are a pharmacist, you are a medical doctor. All these will be able to do. The main contact person, in addition to anybody you know in BSN, the main contact person who is the program manager for healthcare is Larry Olorutobi. And his number is reflected. If you're interested in any of the leadership program from BSN for healthcare practitioners, please snap this page, make a call to him, or send a note to his email address, and we'll be able to get you properly educated and enrolled for the program. We want to thank Dr. Richard Ajayi. We share a number of key issues with us. He spoke about the need for us to have vision. He summed it as visa, really. And for leaders in the healthcare space should be able to drive vision, integration, irrespective of which profession you begin, let's work together, and let's work on the process in terms of systemization and the need for us to take action. And he sees that currently we have been forcing square pegs into round holes. It is time for us to just fit square pegs into square holes and round pegs into round holes. The second speaker, Dr. Ogunyemi, the special advisor to the governor, spoke about the Japa syndrome. I say it's time for us to convert. Sorry, this word is convert. The need for us to convert brain drain into brain gain. And we should move from the current medical model into multi-dimensional professional model, where there's collective leadership and inclusive leadership, and the need for us to enhance to work with government under a PPP arrangement in helping to transform healthcare delivery. So each side we have something to do, and that can only be done through appropriate and inclusive leadership at both private and public sector. Then he encouraged us to grow our knowledge, to grow our skills and our masteries, to go back to school and read more. And now going back to school has really been of great help to her. So not only did she have her first degree, but she went back to have 3 additional degrees, 2 different masters, and then eventually went for a doctorate degree. And that has helped her in her career trajectory since she came back to the country. And today, she's already at the peak of the policy making in Lagos State. And based on whatever she's able to do, might be able to look out for her at the national level sooner than later. Dr. Pounds started with a film by Dr. Rajiv Shah, a medical doctor, who openly canvassed for support and work for other professionals, because the doctors and the nurses don't have enough time, and that medication adherence costs as much as $300 billion and accounts for as much as about 10% of the cost of total healthcare delivery. There's a recommendation, therefore, for medication therapy management, as explained by Dr. Pounds, which invariably decreases length of stay in the hospital or decreases the number of times that the patient will have cause to come back to you and disturb other healthcare practitioners. Like the case of Sarah. For 18 months, she did not have cause to be admitted. For somebody who used to be admitted an average of 3 to 4 months every year. And so there'll be decrease in length of stay. Hospital resources can be utilized for more people. There's a need for task shifting and collaboration. That's why the title is collaborative leadership. To be able to influence the service to the patient, you need to be better. Then she spoke about pharmacists, either as representative of companies or as clinical pharmacists in the hospitals, play a very key role in educating physicians about medicine. The pharmacist is involved with drug discovery, drug development, drug marketing, and indeed, pharmaceutical representatives are the ones who first of all share the knowledge of drugs in most developing countries with the physician. And it is an irony that I saw a note that says pharmacists should not be allowed to participate in World Round. It's like, maybe I'm just waking up to realize that we are still in the 16th century, in a country that's supposed to be running a 21st century system. It just shows that, and I just felt that what we really require is education. We need to educate ourselves so that people can get to understand that the practice that was in place years backward may not be the best practice today. And that all of us have similar roots. About 2,200 years before Hippocrates was born, there's a guy called Imhotep. Imhotep happens to be a black, it's an African. And he was the one who first of all extracted over 200 medicines from plants. And eventually, so he practiced first as a pharmacist, and because of his knowledge of medicine, extraction of medicine from plants, he eventually practiced also as a medical doctor. And so medicine and pharmacy had always been like identical twins. But each one of them has made choices as to what they want to focus on. And it will be important for collaboration to exist and a multidisciplinary approach to patient care. That is the way to demonstrate leadership to the patient, rather than unusual, unethical debates and unethical that make the patient look at it and say, are these people really bothered about us or about themselves? And Dr. Pounds recommended the need for us to use the residency approach to build skills and co-leadership in managing our patient. It is clear from the discussion from these three people that collaborative leadership is a powerful tool to drive transformation within the healthcare sector. Our country faces numerous challenges in providing quality healthcare, ranging from limited resources, infrastructure, to addressing widespread healthcare disparity across the different regions of our country. Collaborative leadership can act as a catalyst for positive change and contribute to the improvement of healthcare across the country. And so we must therefore build ability to bring together diverse stakeholders, healthcare professionals, policymakers, community leaders, industry experts, not just the professionals that have been the major focus of our discussion today, not just the healthcare professionals, but policymakers have to know how to engage the House of Reps, the House of Assemblies, the Senate, that they understand that health is wealth. And it's only when we fix the health of this nation that this nation can actually prosper. So, I mean, health of the people of the nation. We need to foster a culture of collaboration within the healthcare sector and leverage on stakeholders' unique insights and expertise to address systemic issues and drive meaningful change. Our collective approach to leadership can help in the development and implementation of policies and strategies that are more responsive to the needs of the population. And you could hear from all the three speakers who spoke about the value of preventive medicine, public health. The more we focus on it through collaborative leadership methodology, the better for us. As leaders in the various healthcare professionals, we must also promote integration of the discipline and encourage interdisciplinary teamwork. Our country is diverse, and healthcare challenges can vary significantly from one region to the other. We should develop a collaborative approach for ensuring that healthcare initiatives are tailored to local contexts and include various cultural and social factors that should be taken into consideration. Even though we are from different healthcare professional backgrounds, we can share knowledge. Like the way Rajiv shared knowledge with Smith, the pharmacist, and both of them collaboratively were able to manage the patient better than if only one of them were to be responsible for managing the patient. Can work together, we lead to more effective and culturally sensitive healthcare delivery. Collaborative leadership, which is what BSN is preaching. We were a little bit concerned, how should we run this program? Should it be doctors alone? Then we realized that it's better to bring different professionals together and let them sit together so that when we have syndicate sessions, where we have case studies, people can hear the different dimensions and different perspectives. We have listened to Dr. Guyemi today. Our perspectives are, and she's been an active participant on what has been happening in the healthcare space, particularly in Lagos State in the last 10 years. So we might be able to use the instrument of collaboration to bridge the gap between healthcare facilities and the communities that they serve, and therefore make healthcare to become more relevant to the community. And as we engage other critical stakeholders, including local leaders, community members, as leaders in the healthcare space, we can also gain more insights into needs of the different communities and population. And that can lead to development of targeted intervention, outreach programs that are better aligned with the realities in the local context and the local communities, and improve access to healthcare services and promoting health equity, so that collectively we can address access, availability, and affordability. And in the context of tech advancement, collaborative leadership can facilitate adoption of innovative healthcare solutions. And that includes implementing digital health system, telemedicine, other technology to improve healthcare. And as we work together with technology experts and industry partners, healthcare policy leaders in Nigeria, we'll be able to harness the power of innovation to overcome infrastructural limitations and enhance the overall healthcare experience for our patients. Ladies and gentlemen, I picked up today that there's a need for us to hold significant power in transforming healthcare as professionals. And if we foster collaboration, cooperation, inclusivity, shared decision-making, healthcare leaders can drive positive change. We can actually transform healthcare. We can improve patient outcomes. We can address the complex challenges faced by healthcare system in various parts of our country. And so collaborative leadership is the driving force in healthcare transformation, and it can lead to a more resilient, more responsive, more equitable healthcare system that meets the diverse needs of the greater population. These have been brought to you by BSN. So we go straight now onto Q&A. And one of the things we like to share under the Q&A is there's a question from Bilikisu Mojirola. I say, how do we resolve the issues of pharmacists not being allowed to go for ward rounds in some healthcare institutions? Maybe Dr. Pans will answer that. Then Dr. Ogunyemi is clear from Temitayo Olotu. We are still lacking behind in collaboration and teamwork. What is the way out? Then Ifeanyi Egunike said to forever, to foster interdisciplinary collaboration, there needs to be policy change that allows all health professionals to work together to improve. Miriam Alisi, just shared the tags. How do we ensure collaborative leadership when we have leaders with diverse culture and belief system? And Ifeanyi also recommends policy change that allows all healthcare to work together to improve healthcare or to even study together. So what are the guidelines to be put in place to ensure that quality, whilst also ensuring affordability for the PPP models in the government hospitals? Miriam Ali is asking that. I'm sure Dr. Ogunyemi. When I studied in Navy, I did some of my courses with medical doctors, some with biochemistry students, science students, and so there's confidence even in the hospital, in Navy teaching hospital, internees, pharmacies, they participate in ward round. And so I don't really know why it's an issue. Either the people are preventing such things, either they are not really exposed into modern practice in healthcare delivery system, or they just choose to take it personal and to feel that no other person knows anything apart from they themselves. But I feel to a large extent that through dialogue, engagement, positive dialogue, positive engagement, more education, and this kind of film that we have shared today, more and more people might be able to see the need for collaborative leadership in the management of patients. On that note, will I ask Dr. Ogunyemi, would you like to provide answer to some of the questions that have been raised? Thank you.
Yeah, thank you. Most of the questions they kind of have the same answer, and you talked about a lot about, obviously that's what we're talking about, collaborative leadership. So let me start with the ward round thing. It's a matter of culture. What is the culture in that hospital? What is it? How is the process? So the consultant walks in, I want to do ward rounds. Does he tell anybody? What's the plan? Is there a time? It's a culture thing, because in the private hospital where I used to consult, they have a ward round that involves the doctors, the nurses, the pharmacists, and sometimes the administrator, just so that they know what's going on within the system. And everybody has a say. I'll give an example. Even when I was at Emory, we used to do sit-down rounds. And then after that, the doctor can, we all walk. But most of the time it's walking rounds. So a patient comes in, has had all the things done, we want to decide whether it's time for the patient to go home. The attending will say, oh, okay, I think we've done, the labs look good, blah, 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 blah. The next person he's going to turn to is the nurse. Who's the nurse looking after this patient? Oh, what do you think? Simple question. He's already said, I think this patient is ready. What do you think? Because the nurse is going to can come up with something that he never thought of. And say, oh, for example, oh yeah, the patient, I say, yes, the patient is ready to go home. However, I spoke to the husband or the wife or the family member yesterday, and they said their house is not ready because they changed the bed, they did this or they're moving house. Maybe we can keep the patient another day. The patient stays another day based on the information from the nurse who is part of the team. Sometimes the physiotherapist could be the one to stop that discharge. The physiotherapist is saying, you know what, I need one more day with this patient because of the stairs. We had this, we had that. So everybody has something because we're all working for that one patient. The patient didn't just come in for diagnosis and then we admitted the patient. The doctor, so when you look at the beginning, the doctor is the leader of the clinical aspect of the patient. He is the one that admits. Let's face facts. The head of the clinical practice, the clinical part of it is the doctor. That is medicine. I want to admit this patient. The rest, he writes a prescription. Who brings out the drugs? The pharmacist. The pharmacist also says, because in America they have PharmDs who are the clinical pharmacists. So we work hand in hand with the pharmacist. When I used to work I get a phone call from the pharmacist saying, that drug, blah, 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 blah. Okay, I'll call the doctor. Between both of us, there's so much collaboration on that one patient because we want the patient to be safe, to have a positive outcome. So the doctor says, okay, I'm admitting this patient for this. He asks, do we have this drug? He doesn't ask the nurse, he asks the pharmacist. The pharmacist, on the other hand, knows what the hospital has been buying, knows what is out in the market, knows all the things that pertain to the drug, can turn around and say, for example, I always use this as an example. Ranitidine, Zantac, is an expensive antacid. So where I used to work, they didn't have that. They had Pepcid, famotidine. So when the doctor comes in and prescribes and said, no, can we change that to, that's the pharmacist telling the doctor that. And so it's really, really good for us to work together. And of course, the nurses are the ones that administer. They're the ones that know the side effects the patient is having. They're the ones that have to report it so that the doctors can have, so with the ward round thing, I don't want to go on about that. It depends on the culture within that hospital. It depends on the MD who's in charge, who can tell the chief, whatever, that, look, no more ward rounds without the nurse or the pharmacist. Then there's going to be a negotiation on the time. You can't just say 9 o'clock when maybe this is happening or what. So everybody comes together and say, okay, why don't we do our ward rounds at 8 o'clock? Why don't we do it at 10? The pharmacist will say why or why not. So that's kind of like a culture thing that we need to do. But it will not change if the leader is not in a transformational collaborative leader. It will not change. It will still be the same thing because the doctors are the one calling the shots. So regarding teamwork, that's where we all of us have to respect each other. The nurse has to respect the doctor. We're not medical doctors. We're nurses, we're pharmacists, we're med lab scientists, and we're doctors. When we respect each other and know that we are together like this, one cannot survive, really do well, be effective without the other. It's that simple. When we all change that mindset from a fixed mindset to a growth mindset, we will be able to make changes within our own healthcare system. We carry everybody along. When you go to a pharmacist, if a doctor goes to a pharmacist and say, okay, please help me about these drugs. I want to give this, I want to give that. This one goes against this one, or that one says, or the pharmacist says, hey, that patient has been on this before, that patient is allergic to this, you cannot give this. That's working together. Not for you, you're not going to take the PharmD from that patient. You're not going to stop the doctor from being a doctor. But guess who wins? The patient wins. The patient has the best information, the best care based on a well-established protocol or whatever it is. You can't write, a doctor can't just write a protocol. The pharmacist has to be there, the nurse has to be there, and all that. So those are the kind of things collaborative. I will go on to ask another person asked about task shifting. I think it was Dr. Omololu, about the culture, the task shifting thing, and that even though it was done, I can't remember how he said it, but he also said that in Nigeria it's done quietly. Task shifting is task shifting. It helps every single profession. We just have to do it well. People have to realize that no, the doctor is not telling me to do his little work. And then we don't hold on to and that is another thing we have here in our culture. We all hold on to our areas. I'm a nurse, hey, that's nursing. Hey, I'm a doctor, I'm a nurse. Well, guess what? It's all a mixed bag. Nursing came from where we were the maidens, we were whatever. You made coffee for doctors, you ensured that the place was clean. That was nurses. It's changed through education, through development. You'll be hard pressed to find, but you know what? Even in America, so we can all come together. And I'll stand up there when I was the ward manager. I used to stand up and I say, okay, does anybody want coffee, tea? He doesn't take anything from me. So I will make the coffee for the nurses, for the pharmacists, and they'll say, yeah, Dr. Blah, 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 how do you have it? it doesn't mean I'm below anybody. It means we're a team and we're looking out for each other. The doctors can come and say, Kemi, would you like some tea? I'll say, yes, please, and all that. And we have some doctors there, would you like a drink? Would you like some water? I'm going to go and get water. It's just respecting each other and ensuring that we're all doing this thing together. That's what collaboration is. So it's that change of mindset. That's why leaders have to be leaders, have to want to be leaders. And then when you're a leader, you shouldn't be afraid of anybody. You shouldn't say, oh, that person is more senior to me. I cannot tell that person what to do. No, you are in charge. If the hospital goes down, you go down. If it goes up, you go up. So it's the good, the bad, and the ugly. So everybody wants to do a good job. So that's the thing about teamwork, about the ward rounds and whatever. It's what the institution, the organization wants to make of it. Ward rounds is not just going to come from one person just saying, okay, I do not want to do ward rounds. If there's a policy that says, this is how we do it, the beginning of the day, you do your ward rounds, everybody knows what's going on. Patients are not telling the nurses or the pharmacists, oh, I'm going home, and the nurse doesn't know anything about it. That is crazy. We all have to be on the same page because it's all for that one patient. That's what I have to say about that. I hope that helps for those who have asked that. And that's what I mean by changing the medical model. It's because we haven't changed our mindset or the system, and we are allowing it to happen as well. And there's no need to fight about it. There's no need to argue about it. It's just sitting down and saying, this is a patient-focused center. It's all about the patient. What is best for the patient? That's it. Thank you.
Thank you so much, Ma. Dr. Pounds, want to address the question briefly? Yeah.
Yeah, thank you. I think the question came from one of the pharmacists in terms of what advice or suggestions that I have in pertaining to the participation in the ward rounds. And I think Dr. Oguyemi probably touched bases on one of them. But I, in my opinion, I think the biggest thing would be for us to come up with a way to change the perception of pharmacists by our doctors. And one way we can do that is to continue to show how important we are when it comes to, taking care of the patients. And that also goes around that patient-centered care. So education is going to be a key. We also need to try to find out, whichever way we can, what the issues are, why our doctors feel like they don't want this model that we're proposing, because the model we're proposing is the multidisciplinary team approach in rounding, in providing certain specialized clinical pharmacy services like nutrition support, like I gave an example of that, maybe anticoagulation. We also need to start with, and I mentioned that when I spoke earlier this morning, we need to look at what is the scope. I think that's probably the biggest opportunity that I see. Do we all understand a scope of practice? For example, as a pharmacist practicing in Nigeria, is it clear to me what my scope of practice is? Is it clear to me that the physician or the doctor, as we call it in Nigeria, is the lead when it comes to taking care of the patient? Is it clear to me as a pharmacist that I am when it comes to medication therapy management, that I'm the discipline in that team that supports the ultimate support, the person that received that is the patient, but I support all the other disciplines the nurses, the physicians in making sure that happens. Is it clear? Because that's my observation as I do what I do in Nigeria, that there may be a need. And maybe there's also an opportunity for the other disciplines for us to look at what actually is the scope of practice. So maybe it's about time for us to, if we agree, we have to get down to the root cause of this. And I really do think that may be one of the root causes that is causing some kind of friction and disharmony between the two groups, you know. So my suggestion would be, let's see how we can address that root cause. It may involve some, you know, we need to just see who are our policy makers that can take that on. But a short-term goal would be, if we have a committee within the hospital, I know here in US, we call it the Pharmacy and Therapeutics Committee. I'm sure there's such a committee in Nigeria, in the hospital. I think the CMD, a meeting probably should be arranged with the CMD in a very professional, positive manner. And we can look at the literature that is out there globally, talks about the power of team approach, the power of multidisciplinary rounds as it pertains to the patient, as it pertains to the cause. All that document could be gotten together. And it really doesn't matter who the champion is. The champion could be a nurse. The champion could be a pharmacist. Like what I'm doing at LUT right now with nutrition support. The champion right now is a nurse, and the pharmacists are part of that team. So whoever that champion is that wants to take that on, come up with the document, present it to your CMD, and present it in the form of an SBAR, situation, background, assessment, and recommendation. Your situation would be, at social and social hospital, we don't have team approach in participation in ward rounds. Pharmacists are, just state it. Background is what is in the literature. And then the gaps. The gaps are going to be what you're currently doing and what's best practice. Your goal is to move to best practice, and then recommendation. Take it to the CMD and then start with that. I think that's all I can really give right now, but I know it's a very touchy subject. I know it's a subject that we really need to, as a group, as a team, kind of see how we can address it, because we know it's best for the patient. Thank you.
Thank you so much, Dr. Pans. We are coming to the end of the program. We'd like you, if you want to join the BSN Healthcare Leadership Transformation Program, do not hesitate to reach out to us either by phone or by email, and we'll be able to give you more details. And it's going to start this Q1, and it will last for about 6 months. And people, we have certificate for it. And we believe that capacity building of this nature is one of the ways we can intervene. And we would like to work with government establishments. Luckily for us, the special advisor on health is here. We need to get government to actually reinforce the need for healthcare practitioners to collaboratively work together. And various sponsors of this kind of training will go a long way in improving the output or the outcome of healthcare activities. And Lagos State government is is the leading state that is investing heavily in the area of health. It would be nice to have an outcome that will also reflect the magnitude. We believe that education is the most powerful weapon which we can use to change the world. And so we will need to drive personal reinvention of of all the key professionals. We have shared for over 2 hours now, and so knowledge is of no value unless it is put into practice, according to Anton Chekhov. We should put into practice the need for us to reach out to engage our professional colleagues in the healthcare team. Whatever be your core profession, reach out to the other. And very intelligent people have a tendency to solve problems, but wise people prevent it. And if you proactively engage, I will proactively discuss possible challenges and problems, we can therefore proactively prevent a lot of problems and facilitate productive outcome for most of the efforts and the investment that have been made into healthcare in our various locations. Today, we have shared information, and I'm sure people have been inspired. Comments have confirmed this. But without application, it leads to frustration. Because information and inspiration without application leads to frustration. But information with inspiration plus application of what we have shared today, what we've learned, it will lead to transformation. That journey for transformation should start today by us taking action and reaching out to our colleagues. We need to be bold, to be brave, and to brilliantly engage. The way Dr. Ogunyemi had mentioned, and Dr. Pans, as well as Dr. Ajayi. I want to thank everybody for this great opportunity. May we ask the program manager, Dr. Lanre Olorutobi, to please give a vote of thanks. Before you give a vote of thanks, I must state that just rushing through the attendees, I came across a number of my other mentors as well, like Dr. Emmanuel Umehe. I want to say a very big thank you. These people have to wake up very early in the morning to be with us. Because of time difference, we are really, really grateful to all the attendees, and God bless you really good. So may I call on Larry, the program manager for healthcare, to please give a vote of thanks.
Thank you so much, LB. Thank you, everyone, for taking our time to be in this webinar today. I heard LB mistakenly called me a doctor. I hope to be a doctor one day. But I would like to thank everyone for taking our time to be here. Firstly, I would like to thank Business School Netherlands, which is the organizers of the program, for creating this initiative. And we're hoping that this initiative will bring about the change in the healthcare industry that we are looking towards. I would like to thank our CEO, Professor Larry Barle, for this opportunity. I would also like to thank our speakers, starting from Dr. Richard Daya Ajayi, for taking our time to be here, even from your busy schedule. I would like to thank the special advisor on health to the Governor of Lagos State, Dr. Kemi Ogunyemi, as well. It's a great privilege to have you here. And lastly, I'd like to thank Dr. Teresa Pounds as well, the president of WASPEN, for also taking our time to be here. We're all hoping that from everything that has been said today, that we can create wonderful partnerships that can help the healthcare industry to move forward from this year and onward, even on to the other years. So we have been putting up a link in the chat box, and if you are interested in starting the healthcare leadership program, the link to the form has been put up. My associate, Temi Tokwe, would also put it up again one more time on the chat box. You can also reach out to me or via my contact details that have been put up by LB. And you can reach out to me at any point in time. I'm always available to answer your questions, and we are hoping we can get this program rolling. So on the last note, I'd like to say thank you one more time to every of the participants here for leaving your busy schedules and your weekends to be here. And we're hoping by the next time we meet, we would have all been transformed in our leadership roles. Thank you, and God bless you.
Thank you. Great, Larry. And thanks to every single person who has made today a beautiful day for all of us. Thank you.
Thank you. Thank you.
Okay. Please,
Thank you.
Dr. kindly send your PowerPoint to us so that we can distribute it.
Okay.
Everybody has attended, we have access to the content of presentation and to the summary that I've already done. We will
Brilliant.
meet with everybody.
Thank you.
All
Thank you.
right. Thank you.
Have a good day.
Thank you so much. We are
All right.
grateful.